Welcome back to the deep dive, where we take all that dense source material, the lecture notes, the clinical guides, all of it, and we give you that shortcut to really understanding it.
Yeah, we do the readings so you don't have to.
Exactly. And today we are stepping right into what I'd call the clinical engine room. We're talking about the absolute non-negotiable bedrock of any patient assessment.
Vital signs and the general survey.
Right. This is where every single clinical story begins.
It really is. I mean, it is the foundational layer. If you think about assessing a patient as like building a skyscraper, the vital signs, and that first general survey, that's your concrete foundation.
You can't skip it.
You just can't. You can't provide safe, effective care, and you definitely can't spot a crisis before it happens without a deep understanding of these indicators. And our sources today are, well, they're a huge stack of clinical notes and classification guides designed to give you that mastery.
So our mission today is pretty critical. We're going to decode the systematic measurement, the nuanced interpretation, and the really high-stakes clinical context of these numbers.
Especially when there's screaming that a patient is in some kind of urgent physiological distress.
We're trying to move beyond just memorizing a list of normal ranges and into the actual art of interpretation.
Precisely.
Okay.
So let's start by defining the core subject. When we say vital signs, what are we actually talking about?
Good question.
We're talking about indicators that reflect a patient's core physiological status and their dynamic response to the environment around them. We're focusing on 5 key measurements.
The big 5.
The big 5. Temperature, pulse, respirations, blood pressure, and oxygen saturation, or SpO2.
Right.
Those 5 form the absolute cornerstone of how we watch over cardiopulmonary and metabolic function.
Okay, so those are the essential 5 numbers. But as crucial as they are, that initial appraisal, that immediate impression you get, it goes way beyond just the numbers.
Oh, absolutely. We also have to collect some foundational physical measurements that give all of that other data some context.
Like what?
So in addition to the 5 vital signs, we have to get objective physical measurements, specifically height and weight.
Okay.
They're essential because they feed into other critical calculations, most notably the body mass index or BMI, and they're also critical for medication dosing.
And even before we touch the patient with any of that equipment, there's that initial human connection, right? The general survey. This isn't just a casual glance, is it?
Not at all. It is a rapid, structured, holistic appraisal. It's what happens the moment you walk into the room.
That first impression.
That's it. The general survey is all the information you collect from that first encounter, and it absolutely sets the stage for the entire rest of the physical exam. If that survey tells you the patient is in acute distress, you stop. You stop the routine assessment and you start intervening.
Okay, let's unpack the components of that general survey because I feel like this part often gets glossed over, but it's so critical. What are we specifically looking at?
We can divide it into 4 major areas. The first one is physical appearance.
Right.
We're making these immediate judgments. Does the patient appear their stated age? What's their apparent gender, their race, their skin color? But most importantly, we're looking at their level of consciousness, their LOC. Are they alert? Are they confused, lethargic? And are there immediate signs of acute distress?
When you say acute distress, what does that actually look like? What are some examples that the sources highlight?
Think about how the patient is presenting. So acute distress could be facial grimacing, maybe they're clutching their chest, or, and this is a big one, they're using accessory muscles to breathe.
What does that mean, accessory muscles?
It means their neck and shoulder muscles are visibly straining to help lift the chest wall. They might even be in what's called the tripod position.
I've heard of that.
They're leaning forward, they've got their arms braced on their knees. It's a posture that maximizes how much their lungs can expand, but it signaled severe respiratory effort. These observations are immediate, they're qualitative, and they're crucial.
Got it. Okay, so the second area is body structure. This speaks more to their physical form.
This covers their build and stature. Are they tall and slender or short and stout? We look at their posture. Are they sitting up straight or are they slumped over? And their nutritional status, are they cachectic, which means sort of wasted and thin, or are they obese? And we're just looking for any obvious physical abnormalities, like tremors or missing limbs.
And then we have mobility, which tells us how they're navigating the world.
Mobility is all about their gait, which is just the way they walk. Is it steady, unsteady? Are they shuffling, dragging a limb? We also look at their general movement and their range of motion, or ROM.
Can they move their arms and legs freely?
Exactly. Or is that movement stiff? Is it painful? Is it limited?
And then finally, the most human element of all, behavior. This is really about observing their interaction.
It is. We're looking at their facial expressions. Do they match the situation? Their mood and affect. And those are different. Mood is what the patient tells you they feel. Affect is how they appear to us.
So are they flat, appropriate, euphoric?
Right. And finally, their speech. Is it clear? Is it slurred? Is their speech pressured, meaning they're speaking so rapidly you can't interrupt them? All these little observations, gathered in seconds in that general survey, they inform everything we do next. They give us the qualitative context that numbers alone just can't provide.
So if that survey tells you the patient seems confused and looks a lot older than their stated age, you know you need to prioritize finding the cause of that confusion. You don't just spend 30 minutes measuring a perfect blood pressure.
Exactly right. The general survey guides the priority of everything that follows.
Okay, let's dig into the rationale for the measurements themselves then. Why these specific numbers?
As we said, vital signs reflect the patient's overall health, their cardiopulmonary function, their total body function. I mean, they're a real-time snapshot of the major systems at work.
And I found the discussion in the sources about establishing a baseline really fascinating. Why is this personal measurement so much more important than just knowing the population average?
Because the individual patient's normal is the only thing we should be tracking. The population range is, 60 to 100 for heart rate, 120 over 80 for blood pressure. They're just averages.
Right, they're for everybody, which means they're for nobody in particular.
Exactly. An elite athlete might have a normal resting heart rate of, say, 45 beats per minute. For you or me, that's bradycardia, a slow heart rate. But for them, it's a totally normal and functional.
The sources had a great example of this.
They did. The elderly person whose blood pressure was always in the 90s over 60s, that was their baseline. So blood pressure of 120 over 80 for them would actually be dangerously high.
Yeah.
It could indicate a fluid overload crisis, even though 120 over 80 is what we all think of as normal.
So we're prioritizing the trend over the absolute number. That seems to be the key takeaway. A deviation from their own personal norm, even if it's still inside that wide population range, that's the real red flag.
Precisely. And that's why tracking trends over time is so essential. We also have to, and this is a big one, always assess patient medications. Any medication, but especially ones for blood pressure, heart rhythm, or pain, can have a huge impact on vital signs. Beta blockers, for instance, they dramatically affect heart rate and contractility, which then directly influences blood pressure. A change in a vital sign might just be the effect of a new dose of medicine, not a new disease process.
And the pace of the measurement, how often we take them, that reflects the pace of the patient's condition.
Yes. The frequency is dictated by their stability and by provider orders. So a stable patient on a standard medical surgical unit might get their vitals checked every 4 hours.
But if they're sicker,
If you have a patient who is, say, post-cardiac surgery or septic, they might be monitored continuously. I mean, sometimes every 5 or 10 minutes, or even every single minute in a trauma bay or an ICU. The sicker the patient, the more frequently you need that data.
we usually collect a full set of all 5, but the notes make a pretty good case for why sometimes you only need 1.
And that's the utility of the focused assessment. If you know the patient has a normal, stable baseline and they tell you they feel feverish, you might only check the temperature after you give them some Tylenol. You don't need to delay that intervention to check the other 4 vitals if the problem is localized to a known fever. It just saves critical time and resources.
All right, before we get into the numbers themselves, let's run through the necessary toolkit. The hardware we need to turn these qualitative observations into hard quantitative data.
The foundational equipment includes a reliable scale and a height bar, a stethoscope, a thermometer designed for clinical use, and critically, a watch with a second hand.
That feels a little old school, but it's essential.
You absolutely cannot count a pulse or a respiration rate accurately without a way to measure a precise time interval. We also need a sphygmomanometer, which is the BP cuff, and we have to make sure we have the right cuff sizes. Too small or too large, and the reading will be completely wrong.
What else?
We need a pulse oximeter, and finally, a tape measure. The sources specifically mention this for getting accurate head circumference and length measurements in infants.
Let's go back to height and weight for a second. They're mandatory for calculating BMI, but there was a really strong critical note in the sources about BMI.
Yes, there was. The source material explicitly mentioned that some very experienced practitioners call the body mass index stupid and the most unreliable number.
Wow.
And that's a significant insight. BMI is a calculation weight divided by height squared, and it's used everywhere in public health metrics and institutional protocols. But it cannot differentiate between body fat and lean muscle mass.
So a bodybuilder could be classified as obese.
Exactly.
Yeah.
A very muscular athlete might calculate as obese using the BMI formula, which clinically makes absolutely no sense.
So we collect it because we have to, but we interpret it with a huge grain of salt. It's a population-level tool being applied, often pretty poorly, to an individual.
Precisely. It's part of the patient record, but it's rarely the definitive indicator of their health status. What's far more important is the daily measurement of weight, especially for patients dealing with fluid stress.
Like in kidney failure or heart failure.
Right. If a patient has kidney dysfunction or congestive heart failure, they can retain liters of fluid and fast. So tracking daily weight changes, and this often requires very precise, consistent morning measurements, is the quickest way to monitor that fluid balance and retention. It tells you if they're heading toward pulmonary edema or if the diuretic therapy is actually working.
We have our baseline. Now let's shift to that high-stakes moment. Identifying deterioration before it becomes a full-blown emergency. Once we have the tools, the next challenge is using them not just to establish a norm, but to catch that patient the moment they start to fail. So what are those immediate, non-negotiable indicators of an urgent situation?
The signs of immediate physiological distress are often visible. We're looking for extreme anxiety or acute distress, the patient who is restless, fidgety, or just clearly uncomfortable. Then we look for critical color changes. Pallor, which is pale or ashen skin, indicating poor circulation.
And the even more urgent ones.
Cyanosis, a bluish discoloration which you'll typically see in the lips, the nail beds, or mucous membranes. That indicates severe hypoxemia or poor oxygenation. That's a huge emergency.
And any sudden change in neurological status is a big one.
Oh, absolutely. A sudden change in mental status, the onset of confusion or non-responsiveness, those are the clearest immediate red flags that the brain is not getting what it needs.
What does it need?
Oxygen, perfusion, or glucose.
I remember the sources had a really critical nugget about acute confusion. What's the quickest intervention to rule out a common cause of that mental status change?
When a patient suddenly becomes confused or disoriented or non-responsive, the immediate first intervention is to check their blood sugar.
Right.
Hypoglycemia, or dangerously low blood sugar, is an extremely common and, importantly, reversible cause of acute confusion. If blood sugar is the problem, a quick intervention, often just a dose of glucose, can reverse the entire neurological change almost instantly. You have to rule out the simple treatable crisis first.
And this philosophy really fades into what the notes called the deterioration principle.
Yeah.
The core message there is that action cannot wait for documentation.
That principle is foundational to safe care. Interventions must begin while the assessment is continuing. If you see signs of rapid deterioration, the patient is confused, they're turning blue, they can't breathe, you start the necessary life support or stabilization measures right away. You call for help first, then you worry about finishing the full data set.
And the mechanism that's designed to catch people before they crash is the Rapid Response Team, or RRT. The notes made a really compelling point. The goal is to call more rapids than codes.
And that's a huge culture shift in medicine. A code means the patient is pulseless and not breathing. It's cardiopulmonary arrest. An RRT is called when the patient is severely sick, but they're still alive and salvageable. It brings immediate critical care expertise right to the bedside to stabilize the situation. The whole emphasis is on catching those subtle changes before they snowball into an arrest.
Okay, let's detail the specific RRT criteria that were mentioned in our sources. These are the acute changes that really signal a systemic failure.
The criteria are pretty standardized, and they focus on major system changes. So for neurological, it's an acute change in mental status, agitation, or severe restlessness. For cardiac, it's new onset chest pain, the classic sign of a potential heart attack.
And for respiratory,
Labored breathing, or significant respiratory rate abnormalities. Specifically tachypnea, which is fast breathing, usually above 25 or 30 breaths per minute, or bradypnea, which is slow breathing, below 8 or 10 breaths per minute.
and then there are the specific cardiovascular rate and pressure triggers.
Right. We look for tachycardia, which is a persistent, unexpected fast heart rate, often above 130 beats per minute, or bradycardia, a persistent slow heart rate, often below 40. And for blood pressure, significant hypotension, which is dangerously low BP, or severe hypertension, dangerously high BP.
This sounds like a really formulaic checklist, but I know the sources clarify that a single isolated abnormal number isn't always the trigger.
And that is the nuance that separates a novice from an expert. Calling a rapid response is rarely based on just one number. If a patient is post-surgery and their heart rate is 120, well, that might be a normal physiological response to surgical pain.
Makes sense.
However, if that patient's heart rate is 120 and they're suddenly hypotensive and they're breathing at 30 times a minute, and their mentation is altered, that cluster of signs signals a true systemic collapse like sepsis or hemorrhage. We always assess the pattern of deterioration, not just a single data point.
All right, let's dive into the specifics, starting with the first vital sign, body temperature.
Okay, body temperature. It reflects the balance between heat production and heat loss, which is essential for our metabolic function. For adults, the general expected oral range is about 96.8 to 100.4 degrees Fahrenheit, with that classic average of 98.6.
But when do we actually define it as a fever or hyperthermia in practice?
Clinically, practitioners will often wait until the reading is consistently 100.4 or 100.5 degrees to formally classify it or treat it as a fever,
Yeah.
unless, the patient has some underlying condition that makes them particularly vulnerable, like being immunocompromised. We also have to consider the pattern of the fever. Is it sustained, meaning a constant elevation, or is it intermittent, where it spikes and then returns to baseline? The pattern helps narrow down the cause.
And pediatric ranges are a little bit higher and narrower.
Yes. The expected oral range for kids is 97.9 to 99.5 degrees. And children also have a less stable thermoregulatory system, which means their temperature can spike much more dramatically with an infection.
Okay, let's tackle the different routes of measurement and how reliable they are. Which one is the gold standard and which one is the one we trust the least?
Rectal temperature is generally considered the most accurate because it's a core body measurement. It's typically about 1 degree Fahrenheit higher than a simultaneous oral or tympanic reading.
And on the other end of the spectrum?
The axillary route under the armpit is the least reliable or accurate. It's usually about 1 degree lower than oral or tympanic. The source notes actually mentioned a provider who said checking an axillary temp is sometimes just confirming the patient still has an armpit.
Laughs. Okay, so not a lot of faith in that one.
Meaning it offers very little definitive physiological data.
What about temporal, the forehead scan?
Temporal temperatures are getting really common because they're so non-invasive. They're usually about 1 degree higher than oral and about 2 degrees higher than axillary readings. The technical aspect is crucial here, though. The probe has to stay perfectly flush with the skin over the temporal artery for the whole scan to capture the heat radiating from that vessel. If the probe lifts or slides, the reading is skewed.
Let's focus on the necessary precision and safety for the rectal route. It seems like the one with the most risk.
For an adult, the probe, which is lubricated and covered, is inserted about 1 to 1.5 inches. The technique requires extreme caution. And the critical safety note is non-negotiable.
Right.
If you meet any resistance upon insertion, you have to remove the probe immediately to prevent perforation or trauma.
And there are specific times when this route is just completely off limits, the contraindications.
The 3 major contraindications are existing diarrhea or any rectal lesions. If the patient is on bleeding precautions, so if they have low platelet counts or thrombocytopenia, because even a gentle insertion can cause trauma and uncontrollable bleeding, or if they have existing rectal disorders or anatomical deformities. If the plumbing just isn't working right, you pick a different route.
And there was also important guidance from the American Academy of Pediatrics about infants.
Yes. The AAP advises against using the rectal route in infants younger than 3 months old because of potential inaccuracies from technique difficulty and anatomical variation in that age group. However, it is commonly used for kids from 3 months to 5 years old when you need an exact core temp, especially if the child is severely ill or their temperature is unstable, because it offers the most reliable reading in a non-cooperative child.
And the expected range for them.
The expected rectal range for that age group is about 98.6 to 99.5 degrees Fahrenheit.
Okay, moving to the tympanic route, the ear. The technique is totally age-dependent to align with the ear canal.
That's right. Proper technique ensures that the infrared beam is actually measuring the temperature radiating from the eardrum. For any patient 3 years and older, you have to pull the ear up and back. For any patient younger than 3, you pull the ear down and back.
Why the difference?
It just reflects the changing angle of the ear canal as the head grows. Also, if there's a lot of earwax or cerumen, the reading will be altered, so you should probably try the other ear or just switch to an oral or temporal route. And again, the AEP advises against the tympanic route for infants 3 months and younger due to general inaccuracy.
And finally, the standard oral route. What are the common pitfalls there?
The oral route is good for cooperative patients, so typically 3 or 4 years and older. The probe has to be placed deep under the tongue. The primary interference is recent temperature changes in the mouth. If the patient just had a big glass of ice water or a cup of hot tea, you have to wait at least 15 to 30 minutes to get a reliable reading. And as you mentioned earlier, you want to avoid oral readings if the patient has any facial or oral trauma, surgery, or if they're a mouth breather, because that constant airflow can cool the probe down.
Let's shift our focus now to the pulse, the heartbeat that we feel over peripheral artery. This is our immediate assessment of the cardiovascular system's efficiency and the quality of perfusion. Tell us about the proper assessment technique.
The technique is crucial for accuracy. You have to use your index and middle finger to palpate the arterial pulse point. You should never, ever use your thumb because your own thumb has a strong pulse that can easily confuse your count.
Good tip.
You apply firm, but not occlusive pressure. You have to find that sweet spot where you feel the impulse clearly without completely flattening the artery.
And when we palpate, we're collecting 3 distinct pieces of data about the circulation, not just the rate.
That's right. First is the rate, the number of beats per minute. We typically count for a full minute if the pulse is irregular, or for 30 seconds and multiply by 2 if it's regular. The standard adult range is 60 to 100 beats per minute.
Okay, second.
Second is the rhythm, assessing the regularity of the impulses. Is it regular or is it irregular? Irregular rhythms, like sinus dysrhythmia, are often normal in children. That's where the heart rate speeds up a little on inspiration and slows on expiration. But in an adult, an irregular rhythm warrants a further cardiac investigation, maybe an EKG.
And the third measurement, amplitude, gives us the strength or the volume of the blood being pushed out. This 0 to 4+ scale provides some crucial insight into their circulatory and volume status.
This scale is a quick, invaluable tool. So 0 is absent, meaning you can't palpate it. That is an urgent crisis requiring immediate intervention. There's no blood flow to that area, or the central pressure is 0.
1+.
1+ is diminished or weak. This is often clinically described as thready. It suggests very low blood volume, like in severe dehydration, or maybe poor pump function.
And 2+ is the goal.
2+ is brisk. This is the expected, normal finding. 3+ is increased, a strong pulse, and then you have 4+.
Full and bounding.
Full bounding pulse. And this is a critical clinical nugget. While a bounding pulse might be normal during intense exercise, if a patient is just lying quietly in bed and their pulse is bounding, it suggests a hyperdynamic state.
What does that mean?
You can indicate significant fluid overload, like in heart failure, or it could be the systemic vasodilation you see in early hyperdynamic sepsis, where the heart is just working overtime to compensate for massive systemic inflammation.
So that distinction is key. A 4+ pulse at rest is an alarm bell, not just a sign of strength.
Exactly. It tells you the systemic vascular resistance is low and the cardiac output is high, which is an unstable state.
And when we're assessing peripheral pulses like the ones in the feet, we also have to compare for symmetry.
Symmetry assessment is mandatory. You have to compare the pulse strength on both sides of the body, right radial versus left radial, or right dorsalis ped versus left dorsalis pedis. If the pulse is diminished on one side, it suggests a localized issue, like an arterial blockage or a vascular obstruction, which is a very serious finding.
What if a peripheral pulse simply cannot be palpated, especially in someone with poor circulation, like a diabetic patient?
If you can't palpate a pulse, you cannot just assume it's absent. The next crucial step is to use a handheld Doppler, it's a small ultrasound machine, to locate and amplify the sound of the blood flow.
And if you find it?
If you successfully locate the pulse with the Doppler, you should immediately mark that spot with a permanent X using a skin marker. This ensures the next provider knows exactly where to apply the Doppler, which saves critical time. A pulse found with a Doppler is documented as a D or Doppler positive, and that is a much, much better finding than 0 absent.
Let's run through the key pulse locations for the listener to reference.
We can categorize them as central and peripheral. The central pulses, which reflect core circulation, are the carotid in the neck and the femoral in the groin.
And the peripheral ones.
The peripheral pulses, which we use routinely to assess distal perfusion, include the brachial, near the elbow, which is often used for manual BP, the radial, on the thumb side of the wrist, the popliteal behind the knee, the posterior tibial on the inner ankle, and the dorsalis pedis on the top of the foot. The pedal pulses are the ultimate check on the quality of blood flow to the extremities.
And again, the age variations are profound here. We can't hold a baby to the same standard as an adult.
Absolutely not. The concept is vital. Infants and newborns have significantly higher expected heart rates because their tiny developing heart muscle has to work faster to maintain adequate cardiac output.
What's the range for a newborn?
A neonate or a newborn has an expected range of 110 to 160 beats per minute. A rate of 70 in a neonate is a severe medical emergency. As the child grows, the heart muscle strengthens, the stroke volume increases, and the rate gradually decreases toward the adult range by adolescence. The acceptable range shifts significantly year by year.
What other key abnormal findings should we be listening for beyond just tachycardia and bradycardia?
Well, we have to be aware of asystole, which is the total absence of a heartbeat, a flat line, requiring immediate CPR. We also need to recognize the significance of something called a pulse deficit.
How is that measured?
It's measured by two practitioners at the same time. One is listening to the actual apical heartbeat with a stethoscope over the heart, and the other is counting the radial pulse at the wrist. If the radial rate is significantly lower than the apical rate, it means some of the heart's contractions are too weak to generate a peripheral pulse, which often indicates serious cardiac instability, like atrial fibrillation.
Okay, let's move on to respirations, the act of breathing.
The definition is simple. One respiration equals one inspiration plus one expiration, a full cycle. And when we're assessing, we look at rate, depth, and rhythm.
The rate is measured similarly to the pulse.
Yes. The rate is the number of full respirations in 1 minute, usually counted for 30 seconds and multiplied by 2, and you have to make sure the patient is unaware you're counting because awareness can alter their pattern. The expected adult range is 12 to 20 breaths per minute.
Now let's talk about the quality of the breath, the depth and the rhythm.
Depth is crucial. Is the chest wall expansion deep, normal, or shallow? If the breath is extremely shallow, the patient may not be adequately ventilating their lungs, no matter what the rate is. And rhythm is the observation of the breathing intervals. Is it regular, or are there pauses or irregularities?
I want to focus on the assessment of effort. What cues tell us the patient is actually fighting to breathe?
We look closely at those general survey points again. Are they using those accessory muscles we talked about? Are they flaring their nostrils? Is there retraction where the muscles between the ribs are sucking in with each breath? Are they breathing in that tripod position? All of these indicate a significant struggle.
And pediatric rates, again, are drastically different.
Newborns start very, very fast, 30 to 60 breaths per minute, and that decreases with age. A key normal finding in newborns is intermittent breathing or periodic breathing. This is a short, benign pause in breathing, up to 10 or 15 seconds, followed by a quick resumption of breaths. If a provider is unfamiliar with neonates, this might look like apnea, but it's a common and normal finding related to the immature brainstem's regulation of breathing.
Let's define the abnormalities, the typnias, and then dive into the more specific, descriptive breathing patterns.
Okay. Dyspnea is subjective difficulty breathing or shortness of breath. Bradypnea is a pathologically slow breathing rate. Tachypnea is a pathologically fast breathing rate, and apnea, the A, meaning without, is the cessation of breathing.
Now, for the critical difference between simply fast breathing and hyperventilation, which also involves depth.
That is the differentiation nugget. Hypoventilation is characterized by a low rate and shallow breathing, which leads to inadequate removal of carbon dioxide. Hyperventilation is characterized by a high rate and deep breathing, which leads to excessive CO2 expulsion. If the person is just breathing fast but the depth is normal, they're just tachypneic. If both the rate and depth are altered, we use the hypo or hyperventilation terms.
But there are specific, highly pathological patterns that can indicate grave neurological or metabolic distress. Let's describe Kussmaul and Cheyne-Stokes breathing.
Kussmaul respirations are a very deep, rapid, and often labored breathing pattern. This pattern is often the body's compensatory mechanism for severe metabolic acidosis, which you typically see in diabetic ketoacidosis, or DKA. The patient is rapidly breathing these deep breaths to try and blow off excess CO2 and raise their blood pH. It's a very distressed, loud, sort of sighing pattern.
And Cheyne-Stokes.
Cheyne-Stokes respirations are an even more ominous pattern, often indicating neurological damage or very severe heart failure. This pattern involves a cycle. Breaths start shallow, they gradually increase in depth and rate, what we call hyperpnea, then they gradually decrease again, and that's followed by a period of apnea, or no breathing. This waxing and waning cycle suggests a failing brainstem regulating center, and it's often seen near the end of life. Identifying these specific patterns tells you not just that the patient is sick, but where the physiological problem lies.
Let's move to the non-invasive measure of oxygenation, SpO2. This is often the fourth vital sign we check, a quick readout of how effectively the red blood cells are carrying oxygen.
SpO2 is the non-invasive, indirect measurement of the percentage of hemoglobin molecules that are currently bound with oxygen in the arteries. It gives us a quick, real-time indication of oxygen delivery.
And the expected normal range is 95% to 100%. We also have to remember that room air, or FiO2, is 21% oxygen concentration.
And this brings us to a crucial clinical implication: the 100% problem, or the risk of hyperoxygenation. If a patient is receiving supplemental oxygen, meaning their FiO2 is greater than 21%, and their monitor consistently reads 100%, we have no idea if they're at 100% or 110%. Since the monitor can only read up to 100%, consistently maxing it out risks oxygen toxicity, which is harmful, especially for certain patients.
So the goal is not always 100%.
Never. The clinical implication is this: if the SpO2 is consistently 100% on supplemental oxygen, the practitioner has to inquire about slowly weaning that oxygen concentration down. We decrease the flow in small increments, 5 or 10% at a time, until the SpO2 drops to a sustained 98% or 97%. This confirms we're giving the lowest effective dose necessary, minimizing the risk of oxygen toxicity while still maintaining an acceptable saturation.
But we have to factor in the chronic disease exception. Not everyone needs to be in that 95–100% range.
This is a vital caveat. Patients with chronic lung disease, like severe COPD or emphysema, have adapted to higher levels of carbon dioxide. For them, receiving excessive supplemental oxygen can actually remove their respiratory drive, causing them to stop breathing. These patients can physiologically tolerate lower SpO2 levels. Often 88% to 92% is their normal baseline. Treating them to achieve 100% saturation can be dangerous, so knowing their history is essential.
Where do we actually measure this, and what causes the most common measurement errors?
Common locations are the finger, the toe, the earlobe, or the foot, especially for infants where the sensor is wrapped around the foot. The key requirement is good peripheral perfusion, good blood flow. If the patient is cold, has low blood pressure, or has poor circulation, the sensor is going to struggle to pick up a reading.
I've also heard of external factors interfering.
Yes. External factors are common causes of error. Dark nail polish, especially black or blue, can absorb the light and give a falsely low reading. Movement artifacts, if the patient is shivering or restless, will also scramble the reading. And most critically, you have to see a stable O2 pleth or waveform on the monitor. If the wave is erratic, or if the monitor is alarming a critically low number, say 65%, but the patient is alert, pink, and talking to you, you must not trust the number. You have to reassess the sensor placement and the perfusion immediately. The clinical presentation trumps a suspect number every single time.
All right, let's get to blood pressure, the force against arterial walls.
Blood pressure is often the most demanding vital sign to measure accurately, especially manually. Physiologically, it's determined by two principal factors: cardiac output, or CO, and systemic vascular resistance, or SVR. The formula is fundamentally important. BP equals CO multiplied by SVR.
This formula really gives us the mechanism of a crisis. If either CO, the volume of blood pumped, or SVR, the resistance the blood meets in the vessels, changes, the BP changes. Can you give us a clinical example of how these factors might change in real time?
Sure. Think about a patient suffering from shock. If they're hemorrhaging or severely dehydrated, their total blood volume decreases dramatically. This lowers the cardiac output. Even if their SVR increases, so their vessels vasoconstrict in an attempt to compensate, the BP will fall dramatically, leading to hypotension.
And the other way around.
Conversely, if a patient is receiving a medication like a vasopressor, that drug causes severe vasoconstriction, which dramatically increases the SVR, and that quickly raises the blood pressure. Understanding BP relies entirely on understanding this CO-SVR balance.
And we measure the pressure exerted against arterial walls in two phases, systolic and diastolic.
Systolic BP, or SBP, is the top number. This represents the maximum pressure exerted during the left ventricular contraction. This is when the heart is actively ejecting blood into the arteries. The diastolic BP, or DBP, is the bottom number. This is the minimum pressure, which occurs during a left ventricular relaxation when the ventricles are resting, relaxed, and refilling with blood.
The equipment list for manual BP is specific, and the site selection comes with some very strict contraindications.
We need the sphygmomanometer, the cuff, the correct cuff size, which again is vital for accuracy, and a stethoscope. Regarding contraindications for arm placement, you must not use an arm with an active IV infusion, an arm on the side where the patient has had a mastectomy due to the risk of lymphedema and infection, or an arm with an AV shunt or fistula, that's a vascular access used for dialysis, as compressing that vessel can damage the access site.
And if both arms are contraindicated, the notes suggest the lower leg. How does that technique change?
You use a larger cuff, and the arterial marker on the cuff has to line up with the artery on the inside of the leg near the tibial area, similar to aligning with the brachial artery in the arm. And you should note that leg pressures are often slightly higher than arm pressures, so you have to factor that anatomical difference into your reading.
Let's tackle the manual measurement technique. The two-step method is mandatory for ensuring accuracy. Why is it absolutely essential to do that palpation step first?
This prevents a dangerous mistake known as the auscultatory gap. In some patients, particularly those with hypertension, the Korotkov sounds, the sounds you're listening for, can disappear entirely for a range of 10 to 40 millimeters of mercury after the systolic sound begins and then reappear later.
So you could miss the real number.
You could. If you don't estimate the systolic pressure first, you might inflate the cuff only to 120, miss the true systolic pressure of 160, and think the systolic pressure started at 100, severely underestimating the patient's blood pressure and leading to inappropriate care.
So walk us through step one, the estimation, detailing that crucial inflation point.
Step 1 is estimation. You apply the cuff. You palpate the radial pulse, and you inflate the cuff until the radial pulse disappears entirely. You note that pressure, and then you must inflate another 30 millimeters of mercury above that noted number. Then you slowly release the cuff to note when the pulse is palpable again. This gives you the estimated SBP. This number tells you the minimum pressure you must inflate to for the actual reading.
So we establish our high inflation ceiling. Now for step 2, the actual auscultation.
Step 2, auscultation. Deflate the cuff completely, and you wait for at least 1 minute to let the vessels recover. Position the stethoscope over the brachial artery, then you quickly inflate the cuff to 30 millimeters of mercury above the estimated SBP from step 1.
And step 3, the reading using the sounds.
Slowly, carefully, you release the pressure, no faster than about 2 millimeters of mercury per beat. You listen for the first clear tapping sound. That is your systolic pressure. You continue deflating, listening to the sounds change, muffle, and finally completely disappear. That point of disappearance is your diastolic pressure. And an essential technical detail for the manual reading. The measurement markings are in increments of 2, so you can only record even numbers.
Let's review the adult classifications, as these ranges dictate treatment protocols for hypertension.
Right, based on accepted clinical guidelines. Normal is less than 120 systolic and less than 80 diastolic. Prehypertension is 120 to 139 systolic or 80 to 89 diastolic.
And the OR is important.
The OR is very important. If either number is high, it falls into that category. Stage 1 hypertension is 140 to 159 systolic or 90 to 99 diastolic. And stage 2 hypertension is anything greater than a 160 systolic or greater than 100 diastolic.
One final, highly specific measurement technique is for orthostatic or postural hypotension. This is a functional problem that causes dizziness or fainting when the patient changes position quickly.
This test diagnoses the body's inability to compensate quickly for gravitational changes in blood flow. The procedure requires 3 positions, measured 1 minute apart. First, you measure BP while the patient is lying down, supine.
Then why?
Then you have the patient sit on the side of the bed with their feet touching the floor for about 1 minute, and you measure the BP again. Finally, you have the patient stand for about 1 minute, and you measure the BP again.
And what defines a positive result?
A positive result, confirming orthostatic hypotension, is defined as a drop of 20 millimeters of mercury or more in the systolic pressure, or a drop of 10 or more in the diastolic pressure between any of the position changes, especially from sitting to standing. And crucially, if the patient reports significant dizziness, lightheadedness, or signs of syncope or passing out, the procedure has to be stopped immediately.
And lastly, the pediatric BP ranges, which are extremely low in infancy.
The trend is key here. Systolic pressure is very low in newborns, often in the 60s or 70s. This is normal because their vascular system is still developing. A systolic pressure of, say, 65 to 78 is normal for an infant. The pressures gradually and continuously elevate toward the adult range as the body grows and the vascular tone matures. A BP of 120 over 80 on a small child, for example, would be a severe critical finding, even though it's normal for an adult.
This deep dive has really confirmed that vital signs are anything but simple. We've navigated from the initial holistic observation of the general survey all the way to the mechanics of pressure and oxygenation. The crucial importance here seems to be that the measurement technique and the clinical context are entirely inseparable when you're interpreting these numbers.
We have to move past the idea that we're just gathering data points. We are creating a dynamic, longitudinal baseline for a specific individual. The subtle trends, the slight deviations from their norm, that low-grade fever that won't break, the heart rate that creeps up slowly over 2 shifts, the BP that suddenly drops 15 points. These are what signal impending trouble far more reliably than an isolated number that just happens to be outside a population range.
And we spent a lot of time discussing the criteria for calling a rapid response team, which is designed to prevent a code. The success of that whole system relies on a provider's ability to interpret these subtle cues.
And that leads us to our final provocative thought for you, the learner, as you continue your journey into understanding health data. If you had to choose just one vital sign that would most accurately tell you if a patient was in immediate, life-threatening, hypovolemic shock, severe bleeding, or dehydration, which one would you prioritize first, knowing all the limitations and contraindications of each measurement?
Ooh, good question.
Think about which measurement reflects the most rapid, profound change in systemic circulation. Ponder that next time you're reading a clinical chart.
A fascinating challenge. Thank you for guiding us through this essential clinical foundation. We'll see you next time on The Deep Dive.